We're ready to get started. I'm Dr. Joseph Namias. My friends call me Yossi, so you guys can call me Yossi. We're very excited about tonight's event, and I see we have a lot of names that we recognize and some names that we don't. As you well know us, we're Alliance Dental Specialist, and we are an office that specializes in endodontics. But I'm going to introduce a young lady here, Martha. Martha is coordinating the event, and she is going to be receiving your questions. So please, on the chat, you can post your questions, and Dr. Al-Kayali.
No, that's okay. Let me move here, and then that way you guys can.
And Dr. Al-Kayali, you're going to have to mute. I'm going to ask everybody, please, to mute your microphones, please.
But I can't hear.
There's some people that have their microphones on. Can you guys hear me? If you can send through the chat and let us know that you can hear us, please. Susan, can you hear me? Okay, yes. So it sounds like they can hear me. So at any rate, again, welcome tonight. And we're going to talk about a very interesting topic. I'm going to just start by introducing you to our office. We are in Oakville. We are a practice that specializes in endodontics. We've been in practice for over 35 years here in the town of Oakville, state-of-the-art practice. I hope that state-of-the-art doctor, even though he's got gray hair now. Bye-bye, guys. And I'm going to show you a little slide with people that are part of our office. Here you see me and Dr. Al-Kayali. And we're very proud that we were voted Top Choice Award last year in 2019, Mark of Excellence. And you can see the staff members that will for sure take good care of your patients. You see the office manager, Ariel. You see the people that answer the phones, Shalene, Martha, Susan, Barbara, Tony, Viviana, and Danielle. Well, let's move on to the next slide. We're excited because we have prepared other events for you. This is our first Zoom meeting now that we are all doing Zoom, and we're doing most of our continuing education from home. We decided that we're going to be part of that as well. So the first event after tonight's event is going to be on Thursday, February the 11th. We're going to be sending you emails to remind you. And Lisa Philp is going to be talking about patient loyalty formula. Satisfaction equals perception plus expectations. So mark it down for February the 11th, 2021. And the next one is an interesting one by Dr. Jose Lanca, and it's on cannabis. Now that we can purchase these things legally, and there's a lot of people, especially younger patients, and the implications of what cannabis can affect your dental practice. So we will send you a link, and we want you to pre-register, and we are probably going to have staff members of yours also being invited, because these are topics that we think are relevant to not only you as the dentist, but also your staff members. So moving right along, I'd like to introduce our speaker for tonight. Our speaker is our associate, Dr. Al-Kayali. And Dr. Al-Kayali comes to us from, she graduated in 2001 from Jordan University in Science and Technology. And she has been a dentist for many years, and she's practiced endodontics for quite a while. Yeah. And she joined our practice before the month before COVID, and then we have to shut down the office, and we were only seeing emergencies. But now we're again working at full capacity. So if you guys need your patients to be taken care of quickly, there's the two of us, and we're going to try to see your patients as quickly as we can, as we usually do. So I'm not going to waste your time anymore by listening to me. I think most of you know me and some of you may not. I've been in practice for over 35 years. And Dr. Al-Kayali's lecture tonight is something that we probably all notice now because our patients are under a lot of stress and they're cracking a lot of teeth. There's no day that doesn't go by that we don't see a cracked tooth in our practice. So she's has decided to name her lecture Cracking the Cracked Tooth Code. So without further ado, here is Arish, and she's going to start her lecture. And please, if you have any questions, you can also send them to her. You can see her email address down there. And please post them on the chat. And at the end of the lecture, she's going to try to answer as many questions as we can. It's nice to see you, even though it's in cyberspace. Maybe next time or maybe next year we'll have events at our office like the ones we've always had, where you guys can come in and we'll have huge events, and that way we can shake hands and not have to wear any more masks and not not live this life that COVID has presented to us. Okay, Arish, go ahead. Take it.
Hi, everybody. Thanks a lot, Dr. Yussi. Good evening, everyone, and thank you for joining us today. I hope you all had a good one. Welcome to our webinar. We will be cracking the cracked tooth code tonight. So I hope you all are ready. If you have any question, please feel free to write it in the chat room. And at the end of this webinar, we will try to answer as many as we can according to the time limit that we have. Interesting enough, I'm not sure about you guys, but just today I saw 4 cases out of 6 which were cracked. So let's begin. So I would like to know how many cases of cracked teeth did you see only last week, or maybe since the shutdown that happened this year because of COVID? Well, let's connect some dots. I want to share with you a video that I found, and I found it really interesting. So let's watch it.
COVID-19 can affect your sense of smell, taste, and apparently your teeth. The virus is sending some people to the dentist, but it's not the virus itself that's hurting your oral hygiene. Let's connect the dots. We are seeing some strange consequences from the coronavirus pandemic, and that apparently includes more cracked teeth. Let's connect the dots. These tooth troubles are not some weird side effect of the virus itself. Instead, it appears to be stress-related. A prominent dentist tells the New York Times he saw more tooth fractures in 6 weeks than he'd seen in the last 6 years. And he blames all the stress associated with this so-called new normal. Everything from COVID nightmares to doom scrolling to virtual learning is causing us to clench and grind our teeth. So what can you do? It may seem weird, but bad posture can lead to teeth grinding. All that working at your kitchen table can cause you to slouch, which can affect the nerves in your neck, causing you to grind your teeth at night. So try sitting up straight. And better bedtime habits can help. Our sleep has suffered during the pandemic, so focus on better quality shut-eye. This means a reasonable bedtime, avoiding devices right before crawling into bed, and staying away from alcohol as a sleep aid. And we just connected the dots.
So I hope with this virtual learning, nobody will crack any teeth. And if you are a clencher, please wear your night guard. So get ready. So because of the COVID-19, they found there's a relationship with the cracked teeth. And let's see some of the titles that going online. COVID and cracked teeth. And why dentists and epidemic cracked teeth brought by COVID-19. Dentists say cracked teeth are more common post-lockdown. Epidemic of cracked teeth brought by COVID-19. More people visiting the dentist for the cracked teeth post-COVID lockdown. And the dentists see surge of problem. The pandemic is likely to blame. Cracked teeth, COVID collateral damage. And one more thing to blame on COVID is your teeth. And apparently that because of the hard time this year that we all passing through, the stress level is increased and the financial demand as well make the stress level increase for people, make them more clenching and grinding and cracking more teeth. And that's a trend that I personally noticed in the practice since we opened back after the lockdown. So let's start with the outline of this lecture. It will be about the cracked teeth definition. We're going to talk about the types, the diagnosis, how to diagnose all the cases, and what's the prognosis that you can present to your patient, treatment option for each case, how we can prevent it, and we're going to discuss some clinical cases to learn from the mistakes. Definition: a crack is a thin surface disruption of enamel and dentine, and possibly cementum, of unknown depth or extension. Now we have two terms. I know most of the dentists, they use the cracked tooth syndrome, but the syndrome by definition is a group of signs and symptoms that occur together and characterize a particular abnormality or a condition. But in the cracked tooth case, it's not a group of signs and symptoms, they come together. It varies a lot, and it keeps changing from patient to patient based on the level and the depth of the crack. So I don't think it's appropriate to use that as a term. Instead, we can use the longitudinal tooth fracture. And we can discuss the types here. Type 1, which is a Craze line, and the Craze line is commonly found in the adult teeth and only involve enamel, often in undisturbed teeth. Of course, it's not always easy to determine the extent and the depth of the Craze line, but the good thing that Craze line usually they don't need a treatment. The second type is a fracture cusp, and it's either complete or incomplete fracture cusp that initiated from the crown on the tooth and extends subgingivally, usually going both mesiodistally and buccolingually. The fracture usually involves two aspects of the cusp, crosses the marginal ridge and extend down to the buccal or the lingual groove. The third type is the cracked tooth, and that's the most mysterious one and the hard to decide on or even to diagnose. It's incomplete fracture that initiated from the crown and it extends subgingivally in the mesiodistal direction and can go through one or both marginal ridges. The fourth type, which is somehow an obvious one, it's the split tooth. And it's a complete fracture that starts in the crown and of the tooth, and it extends subgingivally in a mesiodistal direction, usually through both marginal ridges, and you can see a moving part of the tooth. The last type is the vertical tooth fracture, and it's complete or incomplete fracture from the root at any level and commonly in a buccolingual direction, and usually it starts from the root and it goes up towards the crown. Here we need to stop a little bit and discuss a little more about the vertical tooth fracture because it might mimic other abnormalities that we can find. Like, first of all, the X-ray here, it shows a vertical tooth fracture, and sometimes it's as easy as just trying to see on the margin of a crown or on the margin of the tooth by using the probe just to elevate the gum a little bit, and you might see the crack extending there. It might mimic as well the developmental groove, which usually happen in the maxillary central or lateral incisors, and it's a groove. It starts from the cingulum as the bacteria reach the epithelial attachment, and it causes the developmental pockets to go all the way to the apex. And it mimics as well the periodontal abscess. Periodontal abscesses usually may cause necrotic teeth, and when we do the endodontic treatment, the teeth may not respond only to the root canal, and that might be because the periodontal disease was not addressed. I'm sorry, but if anybody has the mic open, please mute yourself. Thank you. So with the periodontal abscess, as I said, it won't heal after doing the root canal treatment because it needs a periodontal treatment. However, with the periodontal abscess, the pocket, it might be wide. It won't be narrow with a sudden drop with the periodontal top. Now, the endoperial lesion, sometimes, as in this case, it shows like it's a G-shaped, which is characteristic of the vertical tooth fracture. But in this case, it was only an endoperial lesion that there's an endodontic origin, and it causes a sinus tract to be all the way around the gum, and it goes from the periodontal ligament, and it mimics the G shape of a vertical tooth fracture. As simple as just doing the root canal treatment solves the problem. I just want to show you here a table I found on the American Association of Endodontics. I found it very interesting because it summarized all the types. It mentioned the direction, the causes, and the treatment, the symptoms, and it's a beautiful and easy way just to put it as a reminder in your office. Now we're going to talk a little bit about the keys of saving the cracked tooth. How we can save the cracked tooth. The best way is we need to catch the crack before it starts. We need to know how to identify them and what's the classification of them. The characteristic signs and symptoms that the patient may talk about, and it will indicate that there's a problem or there is a crack on this tooth. And how to detect a crack as early as in the development as possible. The earlier we can diagnose before the patient have symptoms, the better the prognosis and the chance of saving the tooth. This slide will be a long slide. I just want to warn you guys, but this is a very important slide. I consider the most important slide in this webinar because we're going to talk about all the steps of detecting the cracks and all the tips with each step that you can use and you need to be careful about when you have the patient, which will make the diagnosis much easier. We're going to start with the dental history. For the dental history, you need to ask the patient if he had, let's say, if he had a cracked tooth before. Sometimes when we start examining the patient, we see a missing tooth and we tell the patient, why did you lose this tooth? He said, maybe I cracked this tooth like last year. And this is an indicator that the patient has maybe a parafunctional habit or a clincher or a grinder, or maybe the way that he eats maybe hard stuff or crunchy food or hard on his teeth, and that's what caused the crack. Repeated occlusal adjustment. The patient mentioned, well, they did many times occlusal adjustment on this tooth, but I still feel I cannot chew on it. So that could be an indicator that not the filling was high or there's a problem in the occlusion, it's cracked. And it wasn't diagnosed because the patient didn't have sensitivity on cold and hot. Sometimes periodontal diseases, advanced periodontal diseases would cause bone loss around the teeth, and this will make it more susceptible for the fracture. Subjective examination. We need to ask the right question for the patient to get the right answer. So we need to ask the patient if they can point out which tooth that they complain about. If they remember accidentally if they bite something. Today per se, I had a patient, he came to complain about one tooth, and I asked him, did you eat anything hard? And funny to say, he just bit on a sesame seed, and sadly, that's a very expensive sesame seed because it cracked the whole tooth. Most of the time, it would be a popcorn. So you need to ask them if they eat anything, especially with the holidays season. People will start eating more candies and they might crack more teeth. Third, to say if they are a clincher or a grinder, they would say yes. You would ask, okay, do you have a night guard? They would say yes. The third question you should ask, do you wear your night guard? Most of the time, 99%, the answer is no. And that's when the patient cracked the teeth. I need to mention as well that wearing the night guard is not only mandatory to wear it at night. Sometimes I ask the patient if they are working on the computer for long hours or if they are watching TV for a long time. And most people tend to clench it during that time. I would ask my patient even to wear it if they don't have to speak. They wear it while they are working on their laptop. And now with working at home with COVID, I guess more people are spending more time on their laptops to do virtual meetings or even to do distant learning. And that might cause, I think, as we saw in the video in the beginning, that it causes a clenching or a grinding and a cracking the teeth. The third thing is objective and visual examination. We need to check the patient. First of all, when we do the extraoral exam, we need to check the muscles and the tensity of the muscle, especially the masseter if it's enlarged. That shows that this muscle have been doing a lot of movement, and that he was exercising that muscles when they're clenching or grinding, and that could be an indication that they have a high forces on their bite, and this might lead to cracks as well. Second thing, we need to check inside the teeth. If the patient has a steep cusps, that means that they might cause excessive occlusal stress on the tooth, and this could lead as well to cracks. When we're checking the teeth, we need to dry the field as much as possible, and we need to check the crack in the area. The darker the crack, the longer it stayed there. and the worse it will be to treat, and the prognosis as well will be depending on the longer persisting crack, the deeper it will be, and the worse prognosis. Fourth, the tactile examination. We need to use the examining probe, the periodontal probe or the explorer, just to go all over the tooth structure, and to see if we can, when we scratch it, we can feel the crack with it. And we need as well to check the gingiva and the gum by touching around the prominent roots to see if there is any dehiscence. That would help sometimes with a vertical root fracture to check if there is any buccal bone left. Again, percussion test. Most people, when they do the percussion test, they do it perpendicular. You should try to do it angular, because usually when the fracture happens, it happens in an angled way. And when you tap in an angular direction, it will help to separate the crack and then initiate the symptoms, like the patient will feel the pain there, and then you can detect the teeth better. The bite test. Bite test, usually we use two types, like the tooth sloth, or I use sometimes the Q-tip, especially if I couldn't produce the response with the bite with the tooth sloth. I would ask the patient to keep biting on the Q-tip till they feel the pain and then stop. However, when you use the tooth sloth, you should ask the patients certain way to bite on it. They should bite slightly, then squeeze slightly and open quickly, because most of the patients, they will feel the pain on the release, not on the pressure. And you keep in mind always to keep in control, like on the opposing, on the contralateral side of the mouth or the adjacent teeth. And keep your eye on the facial expression of the patient, because sometimes the patient will not have the time to tell you, but when you feel the patient that they clench on you, then this might be an indicator that this tooth has a problem. Now, vitality testing. For the vitality testing, checking the bulbal status for the teeth that we suspect that it might have a crack, it would be important for the treatment planning. Besides, it will indicate for how long or the depth of the crack inside the tooth, and if the bacteria reach to the nerve and cause any damage. Periodontal probing. As we all know, probing around the teeth is important because the depth of the pocket there would deflect the depth of the crack. We're gonna go more extensively about the periodontal probing and how you can do it and precisely, and what you should use exactly. Radiographic examination. We know that cracks can rarely be seen on the radiograph unless it's on a buccal or the lingual direction and it coincides with the X-ray in that direction. However, we can see with a periapical radiograph, we can see a G-shaped like pathology in the bone loss, and that could be an indication, as we mentioned before, a vertical root fracture. We should check for the vertical bone loss around the crack, especially if it was on the mesial or the distal side. We should check the radio-opaque line, especially with the teeth that was root canal treated. We should check if there's a radio-opaque line that goes along the root canal filling material. This could be an indication of a vertical root fracture as well. We should check for teeth that previously treated with, if they have post, how wide the post, if it's serrated, how big is the post, and if it's pointed. Usually the short and the wide post would cause more damage to the roots. Restoration removal. Research found that 40% of the crack were missed because the restoration was not removed. Because sometimes you check the tooth and you cannot see anything, but still you can see that the patient has pain on biting, and that's the only sign that you can find. But if you remove the restoration and you check under it, you might find the crack hidden there. So it's worth it that each tooth that we suspect a crack and we cannot see it, that you need to remove the restoration. And from one side you can prop even better on the mesial and the distal of the tooth. From the other side you can check visually if any crack exists. Staining. Staining by using the methylene blue is a very non-invasive, easy way just to check the teeth, and we're gonna show some cases as well about the staining and how it works. Transillumination. So the transillumination, you can use a fiber optic light. Either you will use the special light for the transillumination, you can use the light cure, you can use the fiber optic light from your handpiece even, if you can turn it on without running the handpiece. But you have to eliminate all the light in the room in order to have it dark enough to see the crack. Wedging forces. This is somehow a little bit invasive because you have to remove the restoration and you have to apply forces in the tooth. However, the dentist has to be very careful with the wedging forces because it might cause separation and pain for the patient. So you need to warn your patient that separation may happen. And usually we use that to test if the crack is causing a moving part of the tooth, or if there is an segment that can be separated from the tooth. Surgical assessment. So the surgical assessment, usually we use it when we highly suspect that there's a crack, but we cannot get any test to confirm that there's a crack or a vertical root fracture. So the only way would be to confirm it is to see it. As we know, seeing is believing. We need to open a surgical flap and we need to check it under the microscope to see if there is a vertical root fracture exist. Dental optical coherence tomography. This is a new technology and there was a research about it in 2015. We're going to discuss a little bit more deeper, and that technology, it can detect the crack more precisely than the CT scans, than the transillumination, or even magnification. So, what are the classical signs and symptoms? The most important thing is pain on chewing is the classical signs. However, absence of pain on chewing doesn't rule out the possibility of a crack. That's how varied the symptoms of a crack could be. Cold and hot sensitivity. Again, cold and hot, it's not, it doesn't happen in every case. It depends on the stage or the state with how far the crack extends inside the tooth, and the pulpal status related to that. So if it's in the latest stage, it could be necrotic, or it could be normal to reversible pulpitis or irreversible pulpitis. But it's important to know the cold or hot sensitivity and the level of the nerve damage, so you can treatment plan the case and give the patients the treatment modalities. Isolation of a deep pocket sometimes. So we know that the crack, if it extends deep, we can get a pocket. Unless it doesn't extend that deep, then the pocket will not be existing. But it's not always the sign that the presence of a crack that you need to find a pocket, because if the crack only confined to the crown, then you catch it early enough to be able to save that tooth. So basically, the thing is that there is always a scenario in our head that for things to happen. But when things doesn't make sense, you should always suspect that there might be a crack. Now, small tips for the slide that I discussed before about the diagnosis. We talked about the magnification. I know that all of us, most of the dentists now, they are using the loupes. But let's face it, how much magnification does the loupe give you? Now in the market, it gives maybe 2.5 up to 6.5. I'm not sure. I got my latest loupe. It's 6.5 magnification, but I'm not sure if there's even higher than that in the market. However, the research found that at least you need 13 times of magnification is the minimum that needed to be able to see a crack. Maybe the intraoral camera can give you such a magnification if you get very close to the tooth. However, the microscope can give us a magnification ranges from 2.5 up to 40 times magnification. And that's why using a microscope and the endo is the standard now, not the loupes. Because you need to detect for the cracks whenever you open any tooth. Even if you suspect or not suspecting, you need to check that there are no cracks for that tooth. Again, we say seeing is believing. You can't treat what you cannot see. We mentioned about the periodontal probing, and as I promised you, we need to do if something you're gonna change tomorrow in your practice, I would wish that you would consider using a plastic probe instead of the metal probe. I use it personally, and I even discuss it with Dr. Namias here in our practice, that we tried in every examination said there was a metal probe, but when we suspect a crack, we ask for the plastic one. And we noticed that we can get a deeper pocket detection using the plastic because it's thinner, and that's proven scientifically. So that's why we shifted now from the metal probe, all the kits to plastic probes. I hope you would consider this tip because it could be a lifesaver for your patients, especially the prognosis for the cracked teeth depends on in some research they found that it depends on the depth of the pocket. And you need to know exactly how deep that pocket, because the depth of the pocket reflects the depth of the crack. Now, radiographic assessment. This is a very interesting case to show. I'm not sure how many x-rays you take for the molar as a pre-assessment for the case. Most of the dentists, they take only a straight view. I would recommend you that you take a straight and an angle view. This patient came to the dentist and complaining about a sinus tract, and the dentist wasn't sure. Well, is it the 6 or the 7? The obvious is the 6 has a big periapical lesion, and the root canal wasn't reached all the way till the end. However, taking an angled radiograph, it showed a vertical root fracture. And stating the obvious, the 7 is the cause of the problem of the sinus tract. We cannot say that the 6 doesn't have a problem, it does, but it's not responsible for the sinus tract. And that case went for extraction of the 7 because it was a hopeless. Now for the transillumination. I have a little detective inside of me. So one day I found an apple and I want to see if I can use another source of light. And that's what I used here is the flash from the mobile phone. I dimmed the light in the room, I put the apple, I noticed that there are 2 developmental cracks inside it. And well, we detected that there is a crack there. Meaning to say that you can use, as we mentioned before, you can use even the light cure to detect for the cracks. All what you have to do is you need to turn off the light in your operatory room, try to make it as dark as possible, and then check with the mirror after drying the tooth and applying the light. We talked about the optical coherence tomography, a new technology. This requires a special device. We don't have it in the office, and honestly, it would be nice to have it, but I don't think it would be cost effective. However, the precision of detecting the cracks shows, as in the middle here, it shows that it's highly precise. As you can see here, it shows like 3 cracks on the enamel. Compared to the naked eye, only 1. Transillumination, it shows 2. And the micro CT as well, it shows only 2. Now let's talk about the treatment strategies. We have a Craze line to begin with. The Craze line, as I mentioned before, doesn't need any treatment, but it might be an indication that the patient might be a clincher and a grinder, and the prevention, in my opinion, would be a good way to think about it. Maybe occlusal adjustment for the patient to check if the patient have a balanced occlusion or a night guard. For the incomplete cuspal fracture or complete cuspal fracture, both of them you either decide to retain if it's incomplete or remove it, and the root canal treatment based on the pulpal status, if the pulp was exposed or the patient have irreversible pulpitis, and of course cuspal coverage. For the cracked tooth, root canal is only important if you diagnose that there is a damage, irreversible damage to the tooth. But sometimes I believe that the dentist, they would prefer to do a preventive root canal treatment, which is based on the patient's and the dentist's preference, of course, and cuspal coverage. For the split tooth, usually it would be hopeless unless the split piece can be removed and the rest of the tooth can be saved. For the vertical root fracture, if it's complete or incomplete, it depends on the tooth if it's multi-rooted or single-rooted. If the tooth is single-rooted, then this is a hopeless case. If it's multi-rooted, we can offer an option of amputation. But we need to think about the longevity of the tooth and the restorability as well. Now, a question came up, should I do root canal treatment for all the cracked teeth? Again, we mentioned that the root canal treatment is mandatory, it depends on the pulpal status and the periapical situation. But I put some research here just to show you what the research would talk about it. In 2007, Quill and Rivera, they found that only 20% of reversible pulpitis of a cracked teeth converted to irreversible pulpitis or necrosis within 6 months, and required root canal treatment with none of the other required root canal treatment up to 6 years. So what we are talking about here, that 80% of the teeth can be saved without root canal treatment, only by cuspal coverage. So if you knew that, or if you passed this information to your patient, would the patient be motivated just to do root canal regardless? Another research shows that when promptly managed, cracked teeth with reversible pulpitis could remain healthy up to 30 years, and that was the length of the research. So again, it shows that the teeth can survive if the nerve was not irreversibly damaged. Once, long time ago, I heard this saying, and I'm a big fan of it. I'm a conservative endodontist, but again, we give all the information to the patient, and they would decide with the dentist what's the best for them. The best root canal treatment is the one that was never done, because as we know, the success of the root canal treatment, regardless, it would range from 80 to 95%. It's never will be 100%. Now, let's talk a little bit about the prognosis. In 1984, the prognosis for the cracked teeth was based on when you get inside the tooth and you need to detect the length, the depth of the crack extending inside the tooth. So hopeless teeth were considered if the crack extends mesiodistally and it involves the pulp. However, the poor prognosis was when there is a coronal vertical root fracture that runs mesiodistally, but it's limited to the crown and it doesn't reach to the root. So the only way, if the crack is large enough to reach all the way to the root, this is a hopeless case. If it's only confined to the crown, even if it's involved the pulp, this is considered poor, but it's not hopeless. The good prognosis if it's only confined to the crown and it doesn't involve the pulp. Another classification that came in 2018, they tried to find a way that they can detect the prognosis before they enter the tooth and subject the patient to treatment. And based on that research by Quill and Kaplan, they found that if you have a crack that extends more than 5 millimeters and it's on the distal or the mesial side, then the success would be 41%. However, keep in mind that 41% is not hopeless. It would be the worst thing that if you have a deep pocket there, but it won't be hopeless. I would combine both. So the way that I present it to my patient, if I found, let's say, a 6 or 7 millimeter with a distal crack, I would say that this doesn't have a very good prognosis, but it's not hopeless unless it extends inside the root. If you want me to detect it, I can open the tooth for you and I can check the depth of the crack where it extends. If you don't want that, then you can go ahead with extraction. So again, it's the patient's choice. Now for the prevention. Prevention, I think, is the best thing to be done for the cracked teeth, because once it happens, it's just a matter of time. If it's ignored, that the patient will lose the tooth. So to begin with, we need to make a conservative cavity preparation and cuspal protection, especially for the posterior teeth. So if there is undermined cusp, it's better to have an onlay or even a crown than just doing a filling. Consider a night guard for the clincher and the grinder patients. Minimize dentine removal during root canal therapy, that you don't want to over-enlarge root preparation and end up with vertical root fracture. You need to avoid the post and the build-ups if possible. If you don't need a post, then don't do it. If you have enough ferrule effect, then you don't need a post. Reduce the condensation force during the root canal fracture, the root canal obliteration. So when you do the condensation, especially people who are still doing a lateral condensation, try not to press hard on the tooth, because this might end up to split the tooth, especially when you do retreatment as well. You need to be very careful because the tooth structure is already weakened. Cuspal coverage following root canal treatment. And now that takes us to the next question. When should I make a crown for a root canal treated tooth in general? Based on the research by Isaac in 2016, they found that teeth received the crown 4 months after root canal were almost 3 times more likely to be extracted compared to the teeth that receive the crown within 4 months. So we would say at least within 4 months, the patients, they should have the crown on the tooth after root canal treatment. But when do you think we should crown a tooth that has a crack after root canal treatment? That's a tricky question. It's even more compromised now. In my personal opinion, before the patients even leave the dental chair. So the best thing you can do if you finish a root canal treatment and you don't have time to do a crown, just adjust the bite and take it out of occlusion. So this way, at least you would guarantee that the patient, they would say, we're not going to eat hard things on this side, but they will still eat on the other side. It won't be preventable. Sometimes even eating a piece of bread, soft bread, will crack the tooth. So just take it out of occlusion and ask the patient to crown it as soon as possible. There is no compromise in this. I wouldn't ever tell the patient no, you have time. I cannot guarantee it till you leave my office because it's cracked. It's not to scare the patients, but this is the reality. We saw so many cases that end up to be split teeth and end up to be extracted just because the patients, they didn't went right away to have a crown on. Now we're going to discuss a little bit about some clinical cases. The clinical cases that I'm presenting here, we need to learn from the mistakes. I like to see how people would miss things and how we can make it up in our practice, and instead of we doing the same mistakes. So let's start. Case number 1. A 54-year-old female. Chief complaint: a few weeks I have a pressure sensitivity and feel that the tooth is wiggling, pointing at tooth number 14. When I examined this patient, there was no history of swelling. Extraorally, the tooth was, the submandibular lymph nodes were not tender. The temporomandibular joint was, there was no clicking or pain. Clinically, a crack was noticed on the mesial and the distal marginal ridges. Palpation slightly on the buccal, and percussion sensitivity and mobility. Cold test was negative. When we did the EPT, it was 67 compared to the other teeth, the 1-3 and the 1-5, it was 28 to 30. So this might be a false positive reading. I know that sometimes the dentist may skip a valuable test. Again, we emphasized here about the bite test and the tooth sloth, and which were both positive in this case. When we checked the pockets around the teeth, there was a 5 millimeter distal pocket around this tooth. The other reading were 2 to 3 millimeter. As you can see here, the periapical X-ray shows a radiolucency, and there is no restoration. And that's typically should be an indicator that there's something going on with this tooth. Why the tooth get necrotic and infected, and there's no filling done on it. It either would be a trauma or a crack usually. We did the transillumination, and it shows the crack that extended from the mesial all the way to the distal. The staining again, it shows clearly that the crack extends all the way from the mesial to the distal. So for diagnosis, what do you think about it? I know nobody can answer, but again, it was non-responsive to cold. It was tender to percussion and palpation, so it's necrotic with symptomatic apical periodontitis with a mesial and distal crack. So how should we proceed from here? What are the treatment options that we can provide to the patients? So basically, we give the option either we would open the tooth and see what's going on, and if the tooth is stable, we would do root canal treatment or extraction. The patient didn't want to lose her tooth, so she decided that we will open the tooth and see what's going on. So we found that the crack doesn't extend to the pulpal floor, and the tooth can be saved. So a root canal treatment was done. However, at this point, I would ask the tooth has 5 millimeter pocket, and that's what I mentioned before about the prognosis, that it could be success 41%. But again, we combined it with the previous classification, and we opened the tooth and we found that it doesn't extend inside the tooth. So this gives the tooth a chance it's it's not hopeless, it's a poor prognosis, but it can be saved still. So I attached with after each case lessons to learn. Hopefully I can gather as much information and benefits from that case for you. The importance of a transillumination and staining. Sometimes you cannot see it because you don't have the magnification in your operatory. But maybe with the transillumination and staining, this can be can be shown more obvious to you there. Detecting a vertical bone loss on the periapical radiograph. So I'll go back maybe a little bit to show you this case here. You can see here that there is some widening in the periodontal ligament around it, and this is some vertical bone loss, especially on the mesial side as well, and that's showing that's coincide with the crack. Keep in mind that the occlusal adjustment and cuspal protection after the root canal. The case that I show, they didn't do, we took the photo before we do the occlusal adjustment. But after you finish the case, as I mentioned before, especially because there is a bigger crack like the one that we see there, extending from the mesial all the way to the distal, it would be very helpful for the patient just to take it out of occlusion if you are not going to do a temporary crown on the same time. The prognosis 41% doesn't mean hopeless. As we see we combine both of them and hoping that the tooth will last in the patient's mouth. Case number 2, a 46-year-old female. The chief complaint, I have pain on biting, started 2 weeks ago. My dentist prescribed me antibiotic and ibuprofen. So in this case, the patient has a history of grinding, and the TMJ it has a clicking on the right side, but there was no pain. The submandibular lymph node were not tender and not palpable. In the oral exam, it was tender to palpation percussion, and the cold test was negative. The probing was 323 on the 4-7 on the buccal, and on the lingual 325. But the question is, which probe was used? In this case, a metal probe was used. However, on the X-ray, you can see that on the distal, there is widening of the periodontal ligament, and it shows that it might extend more than 5 millimeters. Clinically, the crack was noticeable. I'm sorry that we didn't attach a photo for this case, but clinically the crack was noticeable on the distal marginal ridge, and it can be shown on the tarsus illumination and the tooth sloth. Both came positive. So what we see here on the periapical radiograph, as I mentioned, there is a vertical bone loss, a necrotic tooth with a very deep crack, and clinically there was separation. We can notice it. It was separable, and there was a darkening in the crack. The diagnosis for this tooth is necrotic with symptomatic apical periodontitis and a cracked tooth. Treatment options were given to the patient. One of the options was extraction, or doing a root canal, trying to see how deep the crack extends inside the tooth. The patient was not willing to save this tooth because she lost the tooth on the other side as well. So she decided she doesn't want to go through the experience again trying to do root canal because the other treatment failed. So extraction was done. My question is, when you have such a case and you want to detect the crack inside the tooth, would you be able to detect it like when you do root canal treatment with loupes only? This is a lower 7, and usually most of the lower 7s and 8s take the big hits and get it cracked first. When we lose them, then the 6 will be the next offended tooth to receive the heavy bite and to be cracked as well. But if you want to save such a cracked teeth, you need to have the tool to be able to decide if you can save that one or not, if the crack extends internally all the way to the root or not. So based on my experience and from what I saw all these years from cracked teeth, I wasn't trying to open the tooth because the crack was deep enough on the radiograph and clinically. So the patients agreed to remove the tooth. Now, lessons to learn. Subjective assessment. When the patient is a grinder, suspect a crack, especially if the patient doesn't wear the night guard. Careful pocket measurements with a plastic probe is more precise. Assessing the radiographic and the vertical bone loss at a crack line is important. Discuss the option with your patient. Again, it's not your decision to make. Sometimes we want to save the teeth, but we cannot save teeth the patient doesn't want to save to begin with. Lost tooth in the arch, usually the 8th of the 7, are mostly affected by crack. Case number 3. Tooth number 44. A 65-year-old female. Chief complaint started having throbbing pain in the lower right side 2 weeks ago while I was on vacation in Florida. I couldn't chew on that side. The DDS in Florida prescribed me an antibiotic. Now, on extraoral exam, submandibular lymph node were palpable and tender on the right side. However, there was no extraoral swelling. The temporomandibular joint, there was no pain or clicking. Intraorally, the tooth 44 was tender to palpation and non-tender to percussion. We couldn't assess the mobility because of the bridge. And periodontal pockets, it was a 323 and a 323 on the buccal and the lingual of the 44. However, a metal probe was used in this case, and there was a bridge, and sometimes it's harder to detect the pockets around the bridge because of the bulginess and the cervical margin. The periapical shows a radiolucency here. Let me move my pointer. It shows a periapical radiolucency in the periapical area. So, what do you think could be the cause of this periapical lesion? First of all, for the diagnosis of this case, it's a previously root canal treated with symptomatic apical periodontitis. But what we can offer to the patient as a treatment option, we need to know what's the cause of the problem, not only to solve the problem. So the patient was sent for a CPCT. And the CPCT results came showing that there is a missed canal. So treatment option discussed with the patient, either to redo the root canal treatment orthograde through the crown or to do an apical surgery. The patient, she doesn't want to lose her bridge, and she doesn't want to pay for a new one because there's always a possibility of losing a bridge when you drill it through it. So a surgery was agreed on. And when we did the surgery, we found a vertical root fracture extending from the bottom all the way to the top. Maybe because we used a metal probe, we couldn't detect that pocket. Or maybe because it wasn't reaching far enough buccally, occlusally, to be detected. So the case shows here that the CPCT indicated that there is no fracture. But is this enough to confirm that there is no fracture? There is a lot of false negative readings on the CPCT. And the only way to know or to confirm that there is a vertical root fracture or there is an absence of it is by doing a surgical exploration and assessment. What we can learn from this case, the importance of using a plastic probe. Keep in mind, probing under the bridge may be difficult. The CPCT can confirm the presence better than confirming the absence of a vertical root fracture. Suspect the false negative results with the CPCT. Case number 4. We are one case away from the end, guys. So for case number 4, we have tooth number 17. A 63-year-old female. Chief complaint, I had pain in the upper right side that radiated to my eye and woke me up last night. I am from Scotland and I'm visiting my sister here. My dentist in Scotland prescribed me amoxicillin 500 mg last week. So the extraoral, it shows non-tender, non-palpable submandibular lymph node. There was no swelling and the TMJ was fine. There was no pain or clicking. Intraoral exam, it shows the tooth that was tender to palpation, percussion. The cold test shows the tooth was very sensitive to cold and it has a lingering sensitivity. Tooth sleuth was positive on the distobuccal cusp. plopping was a 323 and a 323. Again, the plopping was used metal prop, not a plastic one. For the diagnosis, as we mentioned, it was a lingering, so it's irreversible pulpitis with symptomatic apical periodontitis, and the crack is suspected. Treatment option was given to the patient here, either to do a root canal treatment or to do extraction. The patient, she wants to save this tooth. So, an access was done, and we can detect a crack that extends all the way to the pulpal floor. As you can see here, sorry, I need to bring my mouse. You can see it extending all the way to the pulpal floor. Now we did the staining as well internally, and you can see how big the crack is. However, in this case, the amalgam was not removed completely. I would prefer to remove the whole amalgam filling before I start digging inside the tooth. This will give me more space to check the mesial and the distal pockets in a better way, and it could be as well indicate how bad the crack extending. Well, the patient, after all, we decided that the tooth is not savable and extraction should be done. So you can see in this case, there's a variation between the plopping externally and when we detect the tooth internally. This might be related to the using a metal prop, not a plastic one, and even the forces that was used when plopping. Removal of all distortion is important to detect cracks. We couldn't see the crack under that amalgam filling until we reached inside. We were only suspecting it. The microscope and the staining are important tools to detect cracks, especially for the upper 7. And plopping was a normal. Which plop did you use? Again, I would re-emphasize that you considered using a plastic plop. Now guys, it's time for a question. I'm not sure how many questions we have there. So, do we have any questions, Marta?
The questions, we do have a question regarding if we're recording this webinar, because some people entered a little bit later. So what we're informing them is that we are recording.
Yes, we are.
And what we might do, we're not sure yet. We might upload it to YouTube.
Yeah.
Or we might even be able to send them a link.
Yes. So the webinar will be recorded, but we didn't decide yet if we're gonna upload it. Hopefully we're gonna upload it on the YouTube. But whoever requested to have a link for it, we're gonna send it to it. So please let us know by email, or by now you can just register with Martha, and then we can keep a note and send it to you later.
Well, I like to add a couple of things. Firstly, I'd like to thank Dr. Al-Khayali for an excellent presentation. And she is right. Even today, myself, I had 2 or 3 patients with cracked teeth, one of which I had done a root canal treatment on a lower 7, and we had found a small crack in the distal portion. There was no probing or not probing, and when we entered the tooth by doing the root canal treatment, she had a necrotic pulp, and that's why we did the endo. And she had it done about 3 months ago, and today she ended up coming in and she had split the tooth completely. So it is important for patients to get the teeth and the endodontically treated teeth, especially the 7s, get full coverage immediately, otherwise they'll lose the teeth. I think that if you have any questions, and I know the next slide, Arish is going to show her email address.
Yes.
You can send her an email and ask her questions. We are going to upload somehow this presentation and send you a link. Another thing that we need to know from you, if you don't mind sending either Dr. Arish or sending Martha, and you can see it in the chat.
Yeah.
If you can send your email address, so we can send them a certificate, so you can get your points, and that way we can email you a certificate. But I'd like to thank Dr. Al-Kayali again for this very valuable information, and I'd like to thank all of you for spending your Thursday evening here with us. And as I always say when I give lectures, we're only a phone call away, or we're only an email away, and you can count on us to help you with difficult cases, especially now that we are in a lockdown situation and it's difficult, but we'll try to answer your questions as quickly as possible. Apparently there's a question.
Yes.
Martha is saying,
Do you
yes.
want me to read it?
Yeah, go ahead, read it.
Okay. Do you think if a crack is suspected, referral to endodontist to see under microscope should always be done as opposed to experimentally removing the resto to see if the crack is shallow enough?
Well, as I mentioned before, if you remove the restoration and you want to detect the crack, if you didn't see it, it doesn't mean it doesn't exist, because again, the limitation of your loops. So if you have the access to refer the patient to the endodontist to be able to detect it clinically, that would be the best. However, even if you open the tooth, let's say, and you didn't see the crack, but you're still suspecting it, how are you gonna detect it internally, and you see how far it extends if you don't have the magnification? So answering the question, yes, whenever you suspect a crack, it's better just to refer the patients to the endodontist unless you have a magnification like a microscope in your operatory to be able to detect it. The least thing you can do is if you use the transillumination, you can say yes, it's a crack, but how are you gonna proceed from that point? If you know that definitely the crack is there, or if you were suspecting it, if you're gonna do a root canal, if you're gonna put a crown and it's normal, that would be fine. But if you're gonna do a root canal treatment, you need to confirm to the patient that this tooth can be restored and it's the crack doesn't extend all the way to the radicula and it's not a hopeless case.
Staining the teeth with methylene blue also helps. It's a good diagnostic test, but definitely I think magnification is the way to go. And internally, obviously, because we're working under microscopes, we can see fairly well and quite clearly how extensive these cracks are. But like Dr. Akayali was saying, there's a difference between hopeless and having some sort of poor prognosis. If it was my tooth and somebody tell me, well, you have poor prognosis, but it's not hopeless, I like to have the root canal treatment done or the crown done, and I like to try to keep the tooth for as long as I can. And that's how I present it to the patients, because many patients pose the question to me, what if this was your tooth? What is this, your sister's tooth? And I, tell them that it all depends, and it's difficult to determine how long that tooth is going to last. But I think we have another question, Martha.
Yes.
Martha is going to read another question. Yes.
Question number 2. What do you think should be done if you can visibly see cracks on teeth with long-standing amalgam restorations, but patient is completely asymptomatic?
I would replace the amalgam restoration. I would remove it just to make sure that there's no recurrent decay, and I would put a crown on that tooth.
Okay, there's your
Transport
answer.
coverage is mandatory in that case. It's like a bomb waiting to be exploded. You don't know when it's going to be exploded in the patient's mouth, and it will cause symptoms. Luckily, you got it before it started to having symptoms. So you need to act on it, and you need to warn your patient about it.
And it's typical of lower sevens. This is something that we see on a daily basis. You'll see a lower seven with a small occlusal amalgam, no symptoms. And we tend to also, when we do our diagnosis and when you send the patients for consultation, we always look at the teeth under magnification. We always transilluminate the teeth because we want to see if there are any cracks. And even if the patient is not having any symptoms or any pain or any issues, and they have an amalgam and there are clearly some enamel fissures and cracks, I think it is probably not a bad idea to remove that amalgam and to put a restoration and either put an onlay or some sort of a metal crown in order not to reduce a lot of reduction or put some sort of a crown, but you need to let the patient know, and then the patient makes a decision on whether they want to proceed with type of treatment or not.
Well, actually, that was the case of my tooth.
Right.
The 4-6, that I have a crack, but it wasn't, I have no symptoms on it. I just, sometimes it bothers me when I bite on it. No cold or hot sensitivity. I know it was vital, luckily.
And one of the typical things that patients are going to tell you is that, oh, I've had this pain for 2 years. It doesn't hurt me all the time, and I have to bite on it at a certain angle. And typically it hurts when I bite, not when I'm chewing, but when I let go. And that is something very typical of a cracked tooth. They'll pinching the nerve, they're causing pain, and when patients have that type of a problem, we need to act, and the sooner we act, the better. The problem in some of these cases is trying to determine which one is the offending tooth, which sometimes can be quite difficult. I have cases, I have a good referring dentist who came for root canal treatment. He was having those symptoms, and he felt that the problem was coming from a 4-6. We did the testing, and the pain was coming from the 4-7. So sometimes these cases are diagnostically challenging. And I always tell my patients is, if I'm going to make a mistake, I'd rather make it in a conservative fashion. If I'm not able to tell which tooth it is, then I'd rather not do anything. But I also tell them that a crack, unfortunately, with time is not going to get smaller, it's going to get larger. So we try to determine what the offending tooth is. And what I do is I send them home with homework. I tell them, I want you to chew on carrot sticks, celery sticks. I think the tooth is this very last molar, the lower 7 on the right-hand side. Do the chewing, do the biting. We're going to have you back in a couple of weeks, and we're going to recheck it. And it's interesting that it's like they connect the dots. It's almost like the coin drops, and then the next time they come in, they're able to say, oh yeah, you told me which tooth, and then I went home, I started chewing on the tooth, and I could clearly tell that the pain was coming from that very last tooth. So diagnosis is sometimes challenging.
Any more question, Marta?
No. If we could just remind everyone to please send
Their email address.
Yeah, if you could please write your email address in the chat section. That way I could send you your certificate of attendance.
Alternatively, you can send us an email. You can send an email to martha@allianceds.com, and we'll make sure that we'll send you. And there is Dr. Arish's email address. You can send her an email as well. So,
thanks everybody for coming, and wish you all a good night. Thank you, Marta, for the moderation, and thanks, Dr. Namias, for hosting us here.
You're very welcome.
Stay safe, and
Stay
here's
safe.
Martha.
And
Bye,
we will keep
everyone.
our mask on.
Stay safe. Bye-bye.
Have a good night. Bye-bye.
Bye.